All right, it's my real pleasure to introduce Dr. Elizabeth Mynatt, who is the Dean of the Khoury College of Computer Sciences at Northeastern University. Dr. Mynatt joined us in 2022 and has had a distinguished career at Georgia Tech before coming to Northeastern, where she was a Regents and Distinguished Professor. She's led groundbreaking work in artificial intelligence, ubiquitous computing, and assistive technologies, and is an internationally recognized expert in health informatics and human-centered computing. It's one of the reasons that we're so excited and honored to have her as Dean of the Khoury College of Computer Sciences and here today. And she was also recently elected to the American Academy of Arts and Sciences in part or in whole for recognition of the incredibly distinguished career that she has had. So please join me in welcoming Dr. Elizabeth Mynatt.
Thank you very much. So I'd like to walk and talk, but then so I just grab one of these microphones. Will that work? It's a real pleasure to be here. I have thoroughly enjoyed the day, and I'm hoping that a number of the things that I'll be able to mention during my brief time with you this afternoon will be able to connect to a number of threads of conversation, and we'll be able to continue our discussions. As mentioned, I joined just shy of 3 years ago as the Dean for Khoury College of Computer Sciences. And I want to just tell you a few things about the college in relationship to the topics that we've had today, because we are not a traditional college of computer science, and I'd like to connect those threads. So things that are traditional, we have just under 5,000 undergraduates, we have just under 5,000 master's students. But one of the things that you should know is that over 55% of our undergraduate students are in what's called a combined major. That is not a dual degree program, but it's a way of curating combinations of computer science, whether it's with biology, or whether it's with game design, or whether it's in health sciences, or whether it's in philosophy. So what we have is this amazing set of students coming out of these programs that are able to combine and think in intersectional and cross-disciplinary ways, which is exactly the kind of student community that you need for the challenges that we've discussed today. These students participate in, I think, the finest Northeastern tradition, co-op, right? And you heard this from Aaron and from others. They go out on significant work studies, 6-month work studies during their time with you. If you are a company in this area and you're not hiring Khoury co-ops, you're missing out. These students are fantastic. We start teaching them from day one to be ready to go into co-op as sophomores. So they're just not learning the basics of how to, type hello world and do their first programming assignments, but they're learning industry standards around coding, around testing, quality assurance, documentation. They're ready to go into the workforce long before they graduate. Their confidence when they graduate is amazing. So if you're not hiring them as co-ops, find me on LinkedIn and we'll make sure that that's a possibility for you. Also for the master's students as well, you've heard from our master's students, 50% of these students are Align students. Align is an award-winning bridge program that connects students who have a background in anything besides computer science that want to pivot into a tech career. So we have people coming from, we have medical doctors in our Align program, we have lawyers, we have people from all professions that come and then take that 1-year bridge program and then graduate with a master's in computer science, master's in AI, and so on. Again, phenomenal students, our employers love them, and because the Align program provides that diverse pathway, we have over 50% students who identify as women or non-binary in that program as well. So incredibly diverse, incredibly talented, and then of course those students are supported by and trained by an amazing faculty. We have just over 200 full-time faculty members, 50 of them tenure track, 50% of them are teaching, and those faculty are teaching across a network of 9 campuses. So we haven't talked about that much today at Northeastern. You're in the historic campus, the Boston campus, but of course we have campuses in Charlotte, in Portland, Maine, in Vancouver, in Seattle, in California, London, Miami. They're doing great. I checked in on them today. And then soon to be opening with our merger in New York City. So if you're not a Boston-based company, I bet you're connected to one of those geographic regions, and I hope you're able to connect with our faculty and students. The other thing that makes Khoury College unique is our mission. Most academic colleges, especially ones in the tech area, are not mission-driven. We are. Our mission is computer science for everyone. And what that means is that we make a series of commitments, and I will be glad to talk to you further this afternoon about what all that looks like, so that not only is computer science education accessible, and I mentioned our aligned program and combined majors is just one version of that, but that computer science innovation also benefits everyone. What are the commitments that we have to make such that computer science innovation is not just useful to the top 5% in the world, not just useful to early adopters, but has a significant positive impact across all communities. And there's not one area, I think, that is more ready for that level of engagement and commitment than what we see in healthcare. So what does that look like as a faculty? So I mentioned our students. Now I'm just going to spend a few minutes talking about some of our fabulous faculty that are working in this area so you can see the connection of the work they do to the topics that you've discussed. So Byron Wallace, associate professor who works in natural language processing, who has made significant strides in his career around natural language processing for medical records and for medical knowledge, dealing with many of the challenges that were discussed here today. Silvio Mir also works in natural language processing, but he is working primarily also in social media channels. So there was a question earlier this morning about how do we get information that are the true lived experiences and start to integrate that into the healthcare area. So that's an area that Silvio works in. Then we take Molly Akini, who also works in natural language processing, but now she is connecting this to health workers going out into the field. How do you use AI and NLP to empower nurses, to empower home health workers? Those home health workers are going to be working in the hospital at home. Well, how do those nurses then connect across language, connect across culture, connect across different types of traditions, not in the US, but also worldwide? And then we get to Saif Savage, who takes that even further. So Saif is working on AI for workers, and how can workers empower and use AI to produce the types of educational materials that, again, extend not just a hospital at home, but community-based health. So much of health that comes from faith-based organizations, community organizations that are a critical piece of caring for an aging population. I want to point out Wingong Jin and Ben Giori as a radical set of talent that has just joined our college. Wingong just joined from MIT. He works in many of the questions and challenges that we were talking about today, right? How do we understand drug discovery and the potential to get past, for example, those phase 2 trials? We need to improve that rate. Wingong's work is deeply aimed at that, as is Ben Giori, who is looking at computational modeling work, connecting our understanding of biology to new drug and treatment areas. Please look them up and check out their work. However, I want to share some more with you. We also look at the embodiment of health and the embodiment of how we take health into different types of arenas. We look at Tim Bickmore's work. Tim works on the embodiment of healthcare knowledge through avatars and through robotics. Some of his initial work showed the efficacy of having an AI avatar for discharge instructions. You know that feeling when you're about to be discharged from the hospital and someone comes in and talks a mile a minute at you for 2 minutes and then walks out and you've signed a piece of paper saying that you understand and you don't understand whatsoever? Nothing like an AI agent who can empathetically and patiently walk through those discharge instructions with you and then go at home with you to help you then consider the ways of making sure you meet those goals. When I also talk about embodiment, I talk about Megan Hoffman's work. Megan works in this new area called medical making. This is medical prosthetic devices on demand. So think AI 3D printing. She also works in computational knitting that combines both the physical properties of a prosthesis, maybe this is prosthesis to aid in walking or typing or eating, but also being able to build in the clinical constraints of that, and then using AI and machine learning to combine these two types of constraints to produce the truly personalized prosthetic that's needed for that individual. It is an amazing combination of AI constraint-based work that parallels in many ways some of the things that we were talking around drug discovery, right? Being able to put in biological constraints and clinical constraints together to produce the right drug. Megan is doing this in the physical domain. I want to point to Stephen Antilli and Matthew Goodwin. There were a number of discussions around what can we do around wearables, what can we do around technology that goes with people or is able to passively sense them in the environment. Stephen and Matthew have worked in this domain for decades now. Stephen has primarily worked in technologies around aging in place and to support aging adults. MIT to Northeastern, there's a lot of that, where we've been able to connect those threads together. And then Matthew, who is primary in Bouvet, but Carmen and I share so many terrific faculty members. Matthew has also connected this work around working with children with significant autism. And being able to use wearable devices that essentially provide an early warning signal for both the child and for the parents that a particular outburst or emotional distress would occur. What this enables parents to do is to feel more confident going about daily life, engaging in going to the community center, going to the grocery store, going to the movie theater. They have that extra level of assurance to be able to intervene before there could be a dangerous and distressing outburst. And then finally, I want to point to Artie. Artie was supposed to be on our panel with us today, so we miss her, but Artie works in digital phenotyping, again, around sensing, these passive sensing technologies that we were discussing. And Artie has done tremendous work around helping people understand their patterns around sleep, and then being able to inform treatment to aid adults. An absence of sleep is one of the many chronic conditions that underlie the U.S. and other populations, and it is a trigger for the major conditions that we talked about. As Larry said, we don't necessarily, just because it says cardiac disease on our heart attack, on the death certificate, it may be underlying patterns around sleep that may be the important triggers where a positive intervention is possible. And then Herman Saxony, again, another faculty member that we share, as well as Artie, works in how do you take this information around personal health informatics and drive that into family-based and community-based responses. I absolutely adore all of the physicians that we have in this room, but so much of health is family-based. So much of health is community-based, and if we're able to engage information, data-driven recommendations, data-driven support, but then put that in the hands of family and community so that those recommendations are actually enacted and sustained, then we stand the chance to move the needle with respect to many of the chronic conditions that are facing our communities. So that was a lightning tour of some of our faculty, and you're going to hear from a couple more, but then I'm going to steal a few more minutes to give a mini tech talk around some work that I've been involved in, as well as other faculty members here at Northeastern. And this is our focus on care for aging adults in the home, and I think it's a nice complement to the panel that you heard previously talking about the hospital at the home. What we're focused on is the not hospital part, but all the other days of the year when we're looking at older adults wanting to maintain quality of life and independence, but nevertheless, due to a series of chronic conditions associated with aging, face increasing challenges and pressures. And so the question is, how can we support those individuals as well as, importantly, supporting their care network? This latest phase of the work that I've been involved in for the past 5+ years has focused on individuals with mild cognitive impairment. These are individuals that have maybe early stage Alzheimer's. Their goal is, again, to maintain independence at home, and they are working through and negotiating how their changes in cognition is affecting their relationship with their spouse, relationship with their children, and what they're able to achieve on a day-to-day basis. This is as technical as I get from the occupational therapy point of view, but when we're talking about these individuals, we're not talking about behaviors such as toileting, eating, and bathing. We're not talking about supporting activities of daily living. These are individuals where the activities that are being challenged are the instrumental activities of daily living. This is cooking, this is banking, this is cleaning the home, this is transportation, tasks that are nevertheless cognitively challenging and more often than not now involve more and more technology. So how can we create through this work AI partners in care to assist these individuals and their care network around these instrumental activities of daily living? AI Caring is the name of our institute. We're funded by the National Science Foundation, so we're one of the major AI institutes through this latest tranche of NSF funding. And it's a terrific partnership. Georgia Tech, Carnegie Mellon, Northeastern, UMass Lowell, Oregon State, and Oregon Health Sciences University are all working together, again, focused on collaborative and longitudinal support for older adults aging in the home, and looking at questions around how do we understand personalized longitudinal models of human behavior. So again, take that ICU at home, that hospital at home question, and then apply it to all the other days of the year. I think I have probably worked on this question of, did my mom have a normal day, for 20 years now. It's actually incredibly difficult to answer because what my mom does on Mondays is different than what she does on Thursdays. Falls are different than springs. What is normal for her and changes from normal are the types of indication that are important to her and important to her caregivers. Based on these questions of longitudinal behavior, then this is question of, well, how do we recognize any changes and adapt to these changes? Some of this is about diagnosis, but more often it's about how do we provide targeted compensatory support, coordinated assistance for those individuals and for the interactions around them. And then how do we do that around a network of care? So I'm fighting with a guy who's telling me about time, but I'm really doing two things at once. And we're going to continue going through a bit more of this, and then I'm turning to Pedja and to Jennifer. So this is the team of Northeastern working on AI caring. Misha Pavel and Holly Jimison have been working in this space for decades, just renowned experts in support for aging adults. That's me in the middle. Varun Mishra, who has been working on wearable monitoring and just-in-time interventions. And then Daku Wang bringing in AI expertise, especially around generative AI and conversational assistant, and Zi Tan, who works in human-robot interaction or human avatar interaction. So what do we need to achieve and what do we want to try to achieve in AI caring? Well, the first is this question of human activity recognition. Again, I think it's quite close to the types of things that we were talking about with hospital in the home, but in this case, we're not talking about vital signs, but we're asking the question, what is the person doing in the home on a day-to-day basis? How can we recognize those activities without having to have a tailored AI system trained for every single different home? And then use that information to support different types of interventions. This work is being led by Thomas Plotz at Georgia Tech, but what it does is start to provide with us a scalable AI solution to look at understanding when sleeping and eating and socializing and toileting, when these activities are occurring, and then build scaffolded support on top of that. So one example of this could be an ambient reminder system. So you have an individual interacting in their home and then starting to recognize certain activities such as moving into the kitchen to prepare a meal, the sleep being over, leaving food in the microwave, going to the front door to based on someone ringing the doorbell and coming back. These are just the fingerprints of day-to-day life. But once we have that data, we're able to do things like provide custom reminders and caregiver alerts based on this. So one example is we don't have a cool looking fridge like that, but we're able, for example, to recognize when someone needs to be reminded that a caregiver has left food for them to have for lunch. This is something we hear over and over again in family interviews. My husband is forgetful, I'm at work, I've left food for him, but then I come back at the end of the day and discover that he hasn't eaten lunch whatsoever. Right? So having that just-in-time reminder that when you come into the kitchen, the system is able to remind you about, oh yeah, there's lunch, please warm that up. And then, by the way, the second one is putting in the microwave and wandering off and forgetting about it. It seems very simple, but the challenges for AI to be able to do this are particularly interesting and complex. But what's important is that this is a consistent challenge for families day in and day out, grappling with how to support an aging adult. A second area, and Toma Zudobi is here, who can answer all the questions because this was her PhD dissertation, is then how do individuals in the home interact with these systems? There's a huge excitement around conversational assistants, but nevertheless, the design of these systems do not suit older adults terribly well. So Toma's been doing longitudinal field studies of existing AI systems, such as the Google Home, to understand the types of behaviors that older adults exhibit when trying to use these systems and being sufficiently trained. We know, for example, that caregivers and care recipients use conversational assistants in different ways, and we've been able to observe what we call scaffolding behavior. This is essentially the care provider saying, okay, here's a reminder about that food that's been left in the kitchen, and then the care recipient being able to interact with it later. And this back and forth of this dyadic use is incredibly important to these individuals, but we don't see evidence of how to do this with traditional systems. We know that older adults use these systems in different ways, variety of functionality. We went in with it with a very pragmatic, functional point of view, and then what we discovered was our older adults were really chatting up the systems all day long and wanting to engage with them socially. We talked about how AI earlier today can be more empathetic. This is an example where the existing systems, you could say something quite meaningful, like, you know, my wife and I are having our 30th anniversary, and then the system basically says, well, I don't know what to do about that. Okay, say congratulations, and then maybe suggest how to order some flowers, right? It's not that difficult, right? How can we build these systems to be more social and not just overly functional and overly fragile? And then finally, how do we build privacy by design? I mentioned my older adults chatting up the systems. They say things to these systems that they shouldn't share, and they certainly shouldn't be sharing this information to a generative AI system that is going to then learn this information and repeat it back to someone else. So what's exciting about this type of work is that we're able to translate these behaviors and needs by older adults with conversational AI into fundamental AI challenges, the types of things that we've talked about today. How do AI systems unlearn? How do AI systems use knowledge graphs to be able to rein in and provide, what was the word, not bullshit answers to my senior adults? How do we provide the scaffolding around these systems to be able to move forward? So in conclusion, and then I'm going to turn it over to my panel moderating duties, we're in year 4 now for the AI Institute. And one of the things that is exciting for us, I think there was this question about who's collecting data about AI in the home for care. We're collecting a lot of data about AI in the home for care, working from existing data sets led by Jeff Kay at the Oregon Health Sciences University, working with Emory University and their cognitive empowerment program. We have deployments in the Atlanta area. We have test beds in Atlanta and here in Northeastern about to open in January. And then we have a major number of deployment sites in Atlanta, in California, and in Pittsburgh, where we're deploying these technologies, the next round of these technologies in January for longitudinal design and evaluation. So thank you for my time for those 2 mini talks, and now I'm going to turn it over to my third job, which is to introduce both Jennifer and Pedja. Jennifer, I think you're first based on the slides. Now you're going to hear from 2 more faculty members that I haven't told you about yet. Jennifer D is the Director of AI Faculty and Research here in the Institute for Experiential AI. Jennifer is in the College of Engineering, but also jointly appointed to the Khoury College of Computer Sciences, and she is going to be talking to you about AI for complex medical data. Thank you.
Thank you, Beth, for the introduction. So, and thank you for the organizers for inviting me to give this talk. So I'm Jennifer D., professor at the Electrical and Department and also Khoury College of Computer Science. And as Beth said, I'm the Director of AI Faculty at the Institute for Experiential AI. Now, just to give you an idea of the membership of faculty within the Institute, we have close to 100 faculty, 70 of which are core faculty, and we are across colleges at Northeastern. So we cover areas in AI, deep AI, and also ethics. We also cover human aspects with psychology experts, and also media and arts and media design. So you can find us and find someone you can collaborate with easily, because we cover a diverse group. Okay. So first, I'd like to give a bird's eye view of what I do for research. It looks a lot, actually, but basically, because I've been here I've been a faculty for 20 plus years working on foundations in machine learning. And as you know, machine learning and AI can be applied to anything, but I'm like a lot of people here. I'd like somehow, how can I apply machine learning to things that can be helpful to society? And in particular, I get attracted to applications in health. And you've seen that I've diversified a bit. So I have from health, I have collaborations in skin cancer diagnosis, and I'll talk more about that later, so I'll do it quickly. And then the next one is also on subtyping COPD. Then I have collaborations also in environmental health, looking at a lot of different variables from toxicity in water, blood type, and also genomic data from blood of pregnant mothers, and then trying to and product usage of pregnant mothers, and then trying to predict who will get preterm birth. And this is actually led by one of our professors in civil environmental engineering called Akram Al-Shawabke, who was here earlier. And then I also have collaborations with psychology professors. We have great psychology professors here at Northeastern. Lisa Barrett-Feldman, and she's an expert on emotion. And with her, I met with a lot of people thinking about the brain and how ML can help understand it, and also mental health. Also with retinopathy of prematurity with Oregon Health Sciences, and through connections with one of my colleagues, Dennis Ordogmas, who's also a professor at ECE. And then, of course, being in ECE, I got connected to people from our wireless Internet of Things Institute and on radio signal detection. And then also my colleague doing climate. So of course, climate change is here, and I want to help what we can do to help better predictions of and things that can help planners be prepared to do something about it. Now, working with multidisciplinary domains is exciting because I get to make an impact in the scientific domains. But also, the nice thing about that is it pushes the state of the art in my field, which is machine learning and AI. And with that, you see in the blue circle, actually, it allows me to make a lot of novel contributions in a variety of areas within machine learning. When working with real-world domains, I have to work with domain experts, understanding their discipline. But you know, our AI models, our powerful AI models, are becoming more and more inscrutable black boxes. So it led our team to develop more transparent models, interpretable and explainable AI. So I have a lot of work on that. And also, as we see it being deployed in the real world, we want to make sure the AI we build is trustworthy. So you'll see also that we have a lot of work on trustworthy AI and making sure we build AI that's where we do responsible AI as well. And of course, other technical things. So we have made advancements in representation learning, unsupervised learning, working with domain experts. Usually when you query experts, they're not all experts really. So some of them could be uncertain of what they gave us. So we also developed techniques on how do you learn from multiple uncertain experts. So, and that one is a collaboration. It started with a collaboration we had with Siemens, and then we actually have a patent on that. So it actually to showcase some interesting things that can happen with collaborations with industry and practical aspects of things. Active learning is also quite interesting because It allows you to come up with models that are more intelligent. Like instead of just randomly getting the data, you want to intelligently select what to query, what labels to ask experts from. So active learning is our models that do something like that, and we also done a lot of work on that as well, and I think that will be very important and useful for drug discovery and design. And again, we've developed techniques that incorporate domain knowledge into ML, because as you see, a lot of algorithms, you don't want to be blind. We have a lot of expertise about our problem, our scientific domain. How do you incorporate that knowledge into the design? So we also do that thing, do that into our models. And more recently, another thing that I think is very relevant to a lot of problems in healthcare and in health is that when we design machine learning models, you don't just design, you design and then you deploy. But the problem is, oftentimes you see new data, or you expect it to do new tasks and so on. So that's the field called continual or lifelong learning. So we also develop a lot new methods on how do you make your learning algorithms adapt to new things and to changes on the tasks that you wanted to accomplish. And of course, because I work in domains that are high risk, we need to make sure that the model we build are robust. So we develop robust methods and also provide uncertainty quantification to the methods we build so that you know when to trust or not to trust the models that we have. Okay. So I'm going to give two examples of our collaboration and our projects. So one is on skin cancer diagnosis. This is in collaboration with Sloan Kettering Cancer Center in New York. And I like to use this example because this is a long-term collaboration. We have been collaborating with them for close to 20 years. It started with an optical engineer colleague called Mynatt. His name is Mynatt Rahajaksha. And he builds this confocal microscope that allows you to see under the skin. And he came to me when ML was not that popular yet. And then we thought, like, how can we help them make this more accessible to doctors, make them understand what this device can do. And the cool thing about this device is that it allows you to see under the skin, minimizing biopsy. And as you know, for those who have this, usually you monitor large portions of your body to make sure that you don't have skin cancer. So of course, it will be nice if you can minimize unnecessary biopsy. So these are some images on what you can see. We collect 3D stacks, and then so the workflow that we want really. So it's a new technology, and so when we started, we thought about how can we make this more automated and standardized. So we're thinking our dermatology expert recommended that. Really, an interesting thing with skin cancer is that dermal-epidermal junction. So if you can find where it is, it can help us figure out what's going on. So we have this 3D stack. We have to figure out where the junction is, and then guide the imaging system to collect a mosaic. So you can imagine when you do panorama pictures, it's like moving it to give a bigger wide field of view of the images, so that you can take a look at what's going on and see whether there's cancer or not. So we've developed this, and interestingly, in the beginning, again, it was 20 plus years ago. This device wasn't used in practice yet, but in 2017, we now have like a billing code for using this in the clinic. So it's fulfilling to see how things progress with work you do in health. Now we apply AI. Now that you have this mosaic, how can we then apply machine learning to allow us to detect interesting patterns from the data and make it more interpretable? So this is okay. Images are typically highly variable, so we develop, this is a Mynatt, which is a UNet architecture with multi-resolution, and allows you to detect those. And we had better results than competing models. Now, another interesting collaboration is with COPD, with Brigham and Women's Hospital. And this is a multi-center grant. This is the fourth phase of that grant, actually, that they have. And it's from 21 clinical sites around the US. And basically, COPD is a lung disease due to cigarette smoking and pollution, and which makes it difficult for breathing. So in this team, this cohort, they've collected high-resolution CT images, clinical information, and genomic data from 10,000 patients, and track it through every phase of the NIH Center grant. The interesting thing is that they have collected this data, and basically, anyone who has difficulty in breathing and who has been smoking for a long time has been categorized as COPD. But they know it's a heterogeneous disease, and they want to learn and be able to stratify patients so that help with prognosis and so on. So they came to us to seek help with our team to help discover disease subtypes. Just quickly, we incorporate domain knowledge into helping discover disease subtypes. And it allows us to develop novel, basically you can do clustering, you can do, but clustering algorithm typically treats all features equally. And then when we use that, it was able to discover things that they already know. But what they wanted to discover were subtypes where they noticed that some patients actually have faster decline than others, even though they have the same amount of pack years or smoking through time. And we only have data that was cross-sectional, but talking to them, we realized that really they want to figure out trajectories of disease and discover subtypes of trajectories of disease. So with that, we thought of using pack years, which is how many years they've been smoking, and age as a surrogate for time, and also lung function as the y-axis, and then develop a novel technique using mixtures of Gaussian processes to learn clusters of disease trajectories that discovers those different colors of those patterns. And again, I just want to highlight that it allows us to publish in an ML venue, machine learning venue, and also in medicine, in New England Journal. Other interpretable models that we've developed, I just need to do quickly. Clustering is a very difficult problem, a very difficult discovery problem, because let's say I give you a bag of marbles and I ask you to cluster them. You can cluster them based on color, you can also cluster them based on size. So it's not simple, but typical clustering algorithm, just try to find them in one way. We've developed several algorithms that allows you to discover multiple alternative ways to do that. Here we've discovered if you just use all the features, it's blue, blank. Here you don't see anything. And then, but we're able to discover two views, airway and emphysema, which was related to what they know about the disease, which allows us to cluster them in interesting ways. Another interesting thing is that I've learned working with doctors is that they actually have lots of experience, and somehow they want to be able to, somehow that may not be in the data. How to incorporate their experience into the data? So it led us to build models like this, where we start with existing rules, and usually the rules are, is it higher or lower than some feature, some clinical feature value? So we start with that, and then learn to develop a model where you can adjust those rules from the data automatically. So this was our discriminative rectangle method on the bottom. Okay. Then we came up with more models. You can just read our papers. And also, instead of just explaining a black box with univariate information, we also are able to explain black boxes with multivariate, higher order, a relationship between the genes. So given gene input, we are able to discover network structure and relationships between genes from a black box model, meaning a deep neural network model. as well. This is another example where you can use domain expert, where on the image data, if you use a blind attention model, it gives, if you do unguided attention, it might just highlight things that are not necessarily important. In the second, on the image on the right, we incorporated domain knowledge about high-level features that doctors are interested in into our neural net, and it allows us to have better accuracy and also better interpretability for them. So I'd like to end that it's important to come up with interpretable models, to consider the human that you're communicating to in building these models, and the language of the domain, and also so that they can elicit trust. And also it's important as well to make sure the models we build are also trust-deserving as well. Okay, I want to end with that, and thanks students and collaborators to help with it.
Yeah. All right, my name is Khoury Radivojac, professor of computer science at Khoury College of Computer Sciences. I am going to focus only on one singular story. Our research is also comprehensive, but our story is going to be about state-of-the-art, state-of-the AI in a particular aspect of precision health. And for me, precision health has to have a high resolution of understanding disease, of decision-making, of prognosis, etc. So that's why I'm going to take you to the genetics a little bit and talk about a clinical scenario where a patient is brought to a clinic. Usually these are young patients, and they need to be genetically diagnosed. And so this is very important to diagnose these patients. It can alter clinical care. Sometimes it's good for just resolution. What happened to my child? You know, did I do anything wrong, or it just happened genetically? It's good for family planning, and of course, surveillance and therapy for family members also play a big role. As you can see here on the slides, I will not bore you with statistics, but rare diseases are very important. But only 50%, actually less than 50% of all patients are diagnosed. And if you focus even more on this problem, you would even see that there is a Netflix series called Diagnosis, and that will give you quite a bit of an understanding why this problem is important. However, if you're a clinician, you need to report a variant to somebody, to a patient, and say, we will do clinical care based on this variant. Who decides on that variant? How do we even know that this should be the variant? How do we know it's a causal variant? What is sufficient evidence? And is the physician the one who decides, or there's some kind of recommendations and guidelines in the whole system? Well, it turns out there is a whole system. There's a consortia and groups called American College of Medical Genetics and Genomics, as well as Association of Molecular Pathology, that have developed guidelines on when you can use a variant for diagnosis. Those are called pathogenic and likely pathogenic variants, and also benign and likely benign variants that you can exclude from reporting to the patients, and you can speed up various types of the clinical care. So that sort of system, I want to guide you through the system to see what the state of AI is in that system. So every variant, we collect evidence about it. For example, you might see it in a certain number of cases, in a certain number of controls. You can do some kind of experiment in a mouse model, etc. So there's a type of evidence, there's a strength of evidence, which is discretized. It can be supporting, moderate, strong, and very strong, and sometimes if you don't know anything, we call it indeterminate. And of course, there's direction, pathogenic or benign. So once you collect enough of these lines of evidence, you can declare a variant to be pathogenic. It's all the way on the other side, likely pathogenic, likely benign, and benign. And if you don't know anything, this is called variant of unknown significance, or VUS variant. And so one of these lines of evidence is actually computational. So these associations and consortia allow us to use predictors to gain evidence about the variant. So if we have some evidence from a predictor, let's say it predicts high or something like that, then you can use it to add to particular lines of evidence and declare that variant pathogenic, and then the patient gets into a whole new direction. However, computational tools could only be supporting lines of evidence. And so how do we decide on that and which tools to use? There's now about 400 different algorithms that predict the impact of genetic variants. Nobody knows what to use. There's some word of mouth, et cetera, but it's not well studied. And these algorithms, given a variant, it could be a de novo variant, it can be any other kind of variant in a patient, give a score on a scale, which is basically a real valued number. So at what point then can you use it as evidence and actually act upon a patient? Who decides on this? So that is really an important problem. And so ClinGen is one of the associations that has established itself as a big player in this, and they established a computational subgroup where I was, and the goal of our subgroup was to investigate how algorithms are used to collect evidence about variants, to promote them to pathogenic or benign. What are the current practices? When is the prediction clinically useful? And can this be consistent with the previous guidelines, which is basically, I told you, a rule-based systems? If you collect 8 lines of supporting evidence, that's a pathogenic variant. Or if you collect 2 lines of strong evidence, that would be a pathogenic variant, etc. So maybe I should go back just briefly. This group has several MDs, several PhDs, computer science, comp bio people, actually very lively discussions, and took us quite a bit of time to understand each other, probably about 2 years just to understand the terminology, that we were not referring to the same things as when we were talking, and that set us back and then forth and so on. But we came up with the algorithm to calibrate the output of any computational algorithm to give evidence on this discrete scale, supporting, moderate, strong, very strong. And so this is one of these algorithms. It does not need to mean anything to you. On the y-axis is called REVEL. On the y-axis is the sort of posterior probability that we estimate. On the x-axis is the score of this algorithm. And then the horizontal lines are at what score the program reaches a certain level of evidence. For example, the dotted line on the left-hand side means that REVEL reaches supporting evidence at roughly about 0.6 and so on. So you can use it, and we can calibrate now this algorithm to be confidently used. And we have, of course, tested this in many different ways and shown that this is good. So we came up as a whole group with recommendations that are now accepted by ClinGen, and I think they will be promoted into the next level of the official ACMG, AMP, ClinGen, and CAP, the adding associations guidelines. And I don't need to bore you with all of these details, but we have been able to establish that now computational tools can give more than just supporting line of evidence. They can actually give you strong line of evidence. That is good. And now we are using the same algorithm to calibrate all other types of evidence, case control evidence, functional evidence, etc. And finally, we have established that this type of quantification or rigor in the system, in fact, reduces the number of variants of uncertain significance. In only one system that we studied, we reduced that number by about 19 percentage points. So that's a good thing, and I think we are improving the state of AI in variant interpretation and how these variants are used in diagnosis. And soon enough, when population screening starts to take hold, this will be used in probably every human who is born. And so with this, I thank you and turn it to the next person.